Oedema. Oedema is abdominal excessive accumulation of free fluid in the interstitial space and serous cavities. Oedema may be localized, limited to an organ, limb, example, lymphatic oedema, inflammatory oedema, or it may generalize oedema, anasarca, when it is systemic in nature, renal oedema, cardiac oedema, etc. Depending upon the fluid composition and etiological factor, the edema fluid may be transduced or exuded. Physiology of edema. An interferon disturbance in the mechanism of normal fluid balance may lead to edema. Decreased plasma oncotic pressure. Plasma oncotic pressure is exerted by the total amount of plasma protein when tend to draw the fluid into the blood vessel normally. A decrease in the total plasma protein level below 5 gram dl result in lowering of the plasma oncotic pressure and lead to increasing outward movement of fluid from the capillary wall causing edema. Increased capillary hydrostatic pressure. The hydrostatic pressure of the capillary normally tend to derive the fluid through capillary wall by counteracting the force. Pressure. Increase in the hydrostatic pressure more than plasma oncotic pressure may lead to edema. Lymphatic obstruction. Normally the initial fluid in the tissue space escapes by the way of lymphocytes. Therefore, an obstruction to the outflow of this lymphatic channel causes localized edema, called as lymphoedema. Increased capillary permeability and intake capillary endothelial. It is semi-permeable membrane which allows the free from of water and crystalloid but allow very minimal passage for plasma protein normally. But whenever the capillary endothelial it get injured due to the trauma, toxin, chemicals, etc., then the plasma protein leak out of the capillary, result in decreased plasma oncotic pressure and produce edema. Sodium water retention. The hypovolemic condition in the body may lead to activation of various mechanisms lead to oedema. Intrinsic renal mechanism, hypovolemia, stimulation of baroreceptor, vasomotor center, sympathetic outflow, renal ischemia, stop blood supply, decrease GFR, decrease exertion of NF+, sodium water retention, increase blood pressure, oedema. Extrinsic renal mechanism, hypovolemia, renal ischemia, decrease Na+ exertion in renal tubule, angiotensin first, angiotensin second, aldosterone release, increase Na+ and water retention, increase blood pressure, oedema. Antidiuretic hormone ADH mechanism, hypovolemia, increase secretion of ADH by posterior pituitary gland, increase retention of water, increase blood pressure and edema. Renal oedema. General oedema occur in certain diseases of renal origin such as nephrotic syndrome, glomerulonephritis, renal failure, etc. Oedema in nephrotic syndrome. There is persistent and heavy proteinuria may abdomen. It is nephrotic syndrome. Due to this, hypoalbuminuria lead to decreased plasma oncotic pressure. Those result in severe generalized oedema, anasarca. This disease quantity of plasma protein by blood lead to activation of renin-angiotensin aldosterone mechanism which result in retention of sodium water. This sitting of various cycle persistence until the abdomen continue. This nephrotic edema is characteristically more severe and it present in subcutaneous tissue as well as visceral organs. Edema in nephrotic syndrome. Edema also occur in conditions like acute glomerulonephritis, rapid progressive glomerulonephritis. This type of edema is called nephrotic edema. It may cause due to excessive reabsorption of sodium and water in the renal tubule by renin-angiotensin aldosterone mechanism. Nephrotic edema. It is comparatively mild, beginning on loose tissue such as face, ankle, genital, etc. The protein content of this oedematus fluid in glomerulonephritis is quite low, less than 0.5 gram per deciliter. Oedema in acute tubular injury. The acute tubular injury may be caused due to shock, severe hypoxia, toxemia, etc. This damage to the renal tubule capacity for selective reabsorption and is lost. This lead to excessive reabsorption and oliguria. Along with there is excessive retention of electrolyte, increase in blood urea. Clinical feature of renal oedema: pre-orbital oedema, swelling around the eyes; pedal oedema, swelling over the leg; shortness of breath, fatigue, numbness in the hand and feet. Treatment: main focus is to treat the underlying causes of renal oedema. Along with this, diuretics can be used to decrease the severity of oedema, such as fluoxamide, diuretic, लघवी वाढण्यास औषध; स्पायरोनोलॅक्टोन्स, अल्डोस्टेरॉन ब्लॉकर, बॉटल पिल; थायझाइड, diuretics. Cardiac edema. Generalized oedema may develop in the right side and congestive heart failure. Here the edema may cause due to following mechanism: due to reduced cardiac output, congestive cardiac failure, decreased cardiac output, hypovolemia, increased renal mechanism, decreased GFR, external renal mechanism, aldosterone, action of ADH, extrinsic renal mechanism, renal retention of Na plus and H2. The reduced cardiac output cause hypovolemia, which stimulate the intrinsic external renal mechanism along with the ADH secretion. These collectively result in Na plus and water retention, lead to oedema. Back pressure hypothesis: congestive cardiac failure, increase in central venous pressure. It lead to increased capillary hydrostatic pressure, result in transduction oedema. Back pressure hypothesis: due to congestive cardiac failure, there is elevated central venous pressure. This pressure is transmitted backward to the venous end of capillary, leading to increase in related capillary hydrostatic pressure. This result in transduction, causing edema. Forward pressure hypothesis: congestive cardiac failure, chronic hypoxia, injured capillary wall, increased capillary permeability, edema. According to the forward pressure hypothesis, congestive cardiac failure lead to chronic hypoxia. This may further injure the capillary wall and damage the capillary endothelium. This lead to increased capillary permeability, resulting edema. Cardiac edema is usually influenced by gravity, therefore a kind of dependent edema. Clinical feature: cardiac edema, dysphagia, breathlessness, shortness of breath; pedal edema, swelling, fatigue, feeling of suffocation. Treatment: main focus is to treat the underlying cause of cardiac edema. Congestive cardiac failure, along with the diuretics, can be used to control the edema, such as furosemide. To control the blood pressure, B blockers such as atenolol or metoprolol can be used. Pulmonary edema. Acute pulmonary edema is one of the most important of local edema, and it is cause serious function impairment. Pathogenesis. Normally the plasma oncotic pressure is adequate, present the escape of fluid into the interstitial space. Therefore lung are normally free from edema. Pulmonary edema can result due to following mechanism: elevation of pulmonary hydrostatic pressure, congestive cardiac failure, increased pressure in pulmonary vein, imbalance between the plasma oncotic pressure and pulmonary hydrostatic pressure, subsequent increase in pulmonary hydrostatic pressure, Excessive fluid move out the pulmonary capillary into interstitial of this collected interstitial fluid. Initial may get clearance through the lymphatics, but at the capacity of lymphatics to drain the fluid decrease, then it excesses of fluid state accumulate in fluid and of interstitial edema. Due to prolonged elevated hyostatic pressure and high pressure of interstitial edema, the alveolar linking break and fluid is accumulated inside there, leading to alveolar edema. Such alveolar edema seriously hampers the lung function and gaseous exchange. Increased vascular permeability. Blood vessel. It is cause of inhalation of toxic substance, toxic edema, toxic shock, radiation, injury, etc. There may be damage to the alveolar epithelial cell or alveolar capillary endothelium. This leads to increased vascular permeability, result in leak out of plasma protein, excessive fluid. This interstitial edema is further followed by alveolar edema. Pulmonary edema due to acute high altitude. Individual who claim to high altitude without waiting for accomplishment, it lead to adaptation. Usually the changes appear after the altitude or more than 2500 meter of or higher is reached. These changes are seen in form of congestion, edema, fluid in lung, numerous minute hemorrhage. If not treated actively, it may lead to death. The undergoing mechanism mainly due to anoxic damage to pulmonary vessel. However, it proper accumulation at high altitude is allowed to take place. This complication can be avoided. Clinical feature of pulmonary edema: shortness of breath, orthopnea, breathlessness, wheezing, whistling sound while breathing, coughing, chest pain, fatigue. Treatment: main focus on treatment to treat the underlying cause of pulmonary edema. Along with that, diuretics can use such as furosemide, spironolactone, thiazides,